Hello, welcome all to my YouTube channel. If you haven't subscribed yet, please subscribe. And if you all haven't seen my previous two videos, I request you to first of all see those two videos. In my first video, I described all the things about that AMC exam preparation, cost, those things. And in my second video I have explained about the pseudomembranous colitis. In this video I am planning to explain another MCQ, so let's move on. Watch till the end and please share this video among your friends. Because this is very easy for you all to recall the theory knowledge that need for your MCQ exam. If you're going to read the books and gain this knowledge, that will take some time, but just by watching this video you can get the basic knowledge that you need for the MCQ exam. So watch till the end. Okay, I hope you guys are ready. So I'm going to start describing the first MCQ. Let's see. The MCQ given as 65-year-old female was prescribed on amoxicillin for 7 days because she had upper respiratory tract infection. Then she developed watery and mucoid diarrhea with associated cramping, abdominal pain, nausea, fever and vomiting. You all know that answer for this question is pseudomembranous colitis, because that is the diarrhea associated with antibiotics. But they have given another 4 answers. I'm going to describe those 4 answers because that's the topic. They have showed some interest. So next MCQ can come from those topics. This is the way you have to study for the AMC exam, because you can't read a book from cover to cover, any book. So you have to study around the MCQ and get the theory knowledge around the MCQ. So what is this ischemic colitis? This is their first given answer for this MCQ. So you should know what is ischemic colitis. Let's see. So you all have known this knowledge, but all must have forgotten. So let's recall what's this ischemic colitis. So take a book and write down the important points what I'm telling. If the video speed is too high for you, you can pause and write down important points. Before we're going to describe about ischemic colitis, let's have some idea about the blood supply of the intestine. Intestine can divide into 3 parts. First part foregut, which is stomach and duodenum, till the entry of the bile duct, supplied by the branches of celiac artery, which arise from the aorta at T12 level. Second one is midgut. Midgut is duodenum to distal transverse colon. Actually, distal 1/3 of the transverse colon. This part is supplied by superior mesenteric artery, which arise from the aorta at the level of L1, and there are several branches from the superior mesenteric artery. First one is inferior pancreatico-duodenal artery. It supplies pancreas and duodenum. Second one is jejunal and ileal branches. It supplies bulk of the small intestine. Third one is ileocolic artery. It supplies terminal ileum, cecum and commencement of the ascending colon, and this also provides appendicular branch to supply the appendix. Next one is right colic artery. From the name itself, it goes to right side, supply ascending colon. Fifth one is middle colic artery, which supplies the transverse colon. Then third part is hingut, supplies by the inferior mesenteric artery. Branches are left colic artery, which supplies descending colon, sigmoid branches, which supplies sigmoid colon, superior rectal artery, which supplies the rectum. This is the arterial supply. The diagram, you just have to recall this. There are two main arteries you have to keep in mind: main superior mesenteric artery and inferior mesenteric artery. Superior mesenteric artery supplies till the distal transverse colon, and inferior mesenteric artery supply rest of the colon. So there is two watershed areas, that is the most distal part of the anastomosis in these two arteries. Those two areas are the one which are more prone to get ischemia, because those are the two most distal part. We call those part as watershed area. There's two watershed areas. Let's see what. First one is splenic flexure. We call this area as Griffith point. Second one is recto-sigmoid junction. We call this as Swedick's point. So these two areas of the colon are more prone to get ischemia. Then in the bowel ischemia, there is a three type. First one is acute mesenteric ischemia. Second one is chronic mesenteric ischemia. Third one is ischemic colitis. Let's see what is the clinical features of each one and how these patients present. First, I am going to describe about acute mesenteric ischemia. This is due to acute reduction in the blood flow in the superior mesenteric artery, or less commonly in celiac artery. Rarely this affects inferior mesenteric artery. Usually small bowel is the area got affected. They present with severe abdominal pain, and mortality is very high, more than 50%. If not treated, mortality more than 90% due to bacterial translocation and sepsis. So you have to treat aggressively if patient having acute mesenteric ischemia. Commonly due to left heart or aortic thromboembolism, which is an acute, very acute condition. Example in post-MIAF or infective endocarditis. Second one is hypoperfusion. We call this as non-occlusive mesenteric ischemia, as in sepsis. Third one is SMA atherosclerosis. Fourth one is vasculitis. Fifth one is mesenteric vein thrombosis. SMA means superior mesenteric artery. Then let's see what are the symptoms patient present with. Patient usually describe this as sudden onset pain. Intensity can be moderate to severe. On the onset, moderate pain which progresses into severe pain. Later, this can progress into very worsened condition like peritonitis, peritoneism. Then, what is the management? Severe illness with perforation or peritonitis needs urgent surgical intervention. You have to inform the surgical team patient needs laparoscopy or laparotomy. For embolectomy or arterial bypass need to do, and resection of the infected bowel part also doing during the surgery. Next, what are the drugs are available? There is a papaverine, which is opioid antispasmodic, which acts as a vasodilatation. We can use this. Also, after the surgery, we are going to give heparin to prevent further thrombus formation. And there is a standalone treatment which I am not going to describe here because that's never asked. Next one is chronic mesenteric ischemia. This is usually due to atherosclerosis of superior mesenteric artery, inferior mesenteric artery, and also celiac artery. Can affect small or large bowel. Both can get affected. We call this as interstitial angina because time to time patient get abdominal pain. What is the management? If that is severe disease, we may need surgical management, and we can consider percutaneous angioplasty of systemic mesenteric bypass, and we have to manage other coronary vascular disease risk factors. We have to treat for dyslipidemia. Then how this chronic ischemic mesenteric patient present? They can present with weight loss, and they can have postprandial pain, and this is what we call as cytophobia. They fear to take meal because they are getting pain just after taking meal. Examination, there can be abdominal tenderness, and you can hurt abdominal bruit. Also in the ischemic colitis also there can be a abdominal bruit. Third one is our topic of interest. What is this? That is ischemic colitis. Let's see what is this ischemic colitis. So this is the topic they have given for the MCQ. So I am going to describe about this in detailed manner. So wait till the end of the video. If you found anything that need to improve, just comment in the comment section. This is usual due to atheromatous occlusion of mesenteric vessels, usually middle colic artery and inferior mesenteric artery. Other causes are emboli, hypoperfusion as in sepsis, vasculitis, drugs, usually oral contraceptive pills. This is the place where young patient can present with ischemic colitis who are taking contraceptive pills, and cocaine and also antihypertensives. So splenic flexure, I already told that this is a watershed area. This area is the most distal part of the anastomosis, so this is the place that most commonly get affected. Rarely this can present as 5-minute ischemic colitis, that means severe disease where the patient is having necrosis, perforation, also sepsis. So how this patient can present? Usually they present with sharp abdominal pain. The onset of pain is over the hours. Usually elderly patient or rarely can present with young patient who is on oral contraceptive, can have bloody diarrhea, and this is not that much severe pain. This is a moderate pain, and this is, as I mentioned earlier, onset of hours. Examination, tenderness of affected bowel area. Often there will be tenderness in the left iliac fossa. Investigations: full blood count, high WBC and low HP will be, you can note. If you do a ABG, there will be metabolic acidosis with high lactate level, and patient will have high amylase level. You have to do ECG to exclude AF if you suspect acute mesenteric ischemia, and the later more higher end investigations are CECT abdomen and colonoscopy. For every patient we are not going to do these investigations. Usually in the doubt we are going to proceed to these. Also you can do mesenteric angiography. So patient can present with two types. You can present an unstable patient where you have to assess ABCDE. You have to get the IV access. You need to start immediately fluid resuscitation, and you have to start IV antibiotics, preferred broad spectrum antibiotic. And the most important thing is you need to consider bowel rest. You should keep the patient meal by mouth, and you need to do continuous monitoring to assess whether the patient is moving on to sepsis. Examination: you should look for if there is any signs of shock. The patient whether is having low blood pressure with tachycardia, and whether there is a features of peritonitis such as guarding, rebound tenderness and rigidity. Also at the same time you can look for other signs of dyslipidemia, and you can hear loud breath over central abdomen. Let's move on to see what are the associated risk factors to someone to develop this ischemic colitis. Mainly diabetic hypertension, because both these two conditions can cause damage to vessel. Next is AF, and if the patient has undergo aortic surgery, there is chance that in place can get narrowing, and there is a reduction in the blood supply which will lead to hypoperfusion that can lead to bowel ischemia. So after basic investigation we are going to arrange a CECT to look for the signs of end stage bowel ischemia or necrosis. So what are these signs? You can see in the CECT whether there is a pneumatosis colon. That means air in the mesenteric vessels. In this diagram I have shown you there is a air in the mesenteric vessels. Next one, you have to look for whether there is a portal gas. That means they are in the portal venous system and its branches. This also can see in the CECT. I have shown the diagram here. There is shown by the arrow that they are in the portal venous system. Next one is pneumoperitoneum, that free air in the abdomen. This one also you can visualize in the CCT. Also other radiography images also you can see this. This is the from the arrow that shows air in the abdomen. If above present, we have to contact surgical team immediately and we have to go for emergency laparotomy. If above are not present, we have to consider ischemic colitis without necrosis. We have to look in the radiography thumbprinting signs, that bowel wall thickening and submucosal edema. This you can see in the X-ray. This means there is no necrosis but there is a ischemic colitis. Then you have to look for the target sign, hyperemic mucosal and serosal layer of the colon wall. You can see in the CECT. Edematous submucosal layer. Above signs usually in watershed areas. Then if you can't come to a diagnosis, you can go for a colonoscopy to confirm the diagnosis. If it is ischemic colitis, you can see very fragile mucosa, segmental erythema will be there, and there will be erosions, there will be petechial hemorrhage. And you can do the colonoscopy to exclude other conditions such as irritable bowel disease. Management is mainly supportive care, and we have to avoid we have to avoid hypotension, and we have to avoid vasopressin, which can further compromise the blood supply. If patient not improve within 2 to 3 days, or patient condition getting worsened from the onset of condition, we have to get surgical team opinion and we have to go for a surgery. If the patient is having the fulminant disease, that means severe disease, we are getting the surgical opinion on the presentation itself. What are the surgical management? Partial or total colectomy can be done. This is usually done in fulminant disease. Second one is partial colectomy. Usually we are doing partial colectomy in recurrent sepsis or chronic segmental colitis. In chronic segmental colitis, we are doing partial colectomy. Outcome mostly resolve. Some may develop strictures. What are the complications? Patient can develop. Complications are patient can develop perforation, worst case scenario, and patient can go into sepsis, and patient later can develop strictures. So thank you for watching. We'll meet on the next video series.